Welcome back to our live Get Expanded discussions. Our mission here is to bridge the gap between patients and providers and to provide answers to all of your questions around airway health, jaw development, and expansion-based treatments. Tonight, we have a very special guest expert. But before we introduce him, I'd like to introduce our newest addition to our live calls and our main host for the night, Girl Jaw. Girl Jaw has been a very active member of our community and a strong supporter since the early days of Get Expanded. And not only that, she's a subject matter enthusiast, a patient, and a patient advocate. And with her presence tonight, we're going to have some very engaging conversations. Be sure to check out her socials. I'll leave them in the description box below. She shares her entire personal airway expansion journey, so you don't want to miss that out. How are you doing, Girl Jaw?
I'm doing great. Yeah, thanks for having me on.
Absolutely, it's an honor. And fittingly, the doctor who performed her expansion treatment is also our main guest expert of the night. And I'd like to introduce Dr. Zubad Newaz. Yeah, buddy. Dr. Newaz is highly recognized for his expertise in airway-focused orthodontics, complex cases, and TMJ-related conditions, treating patients globally from his practice in Ponte Vedra Beach, Florida. Is that correct?
That's correct.
That is correct.
And New York.
Well, he actually has, he has, you have three?
And
Three.
Philadelphia and New Jersey
Just
with
get 'em
Dr.
out.
5, 6.
It's global. There you go. Dr. Newaz, how you feeling tonight?
Feeling great. A little tired after a long weekend, but pretty good.
Yes, of course. And thank you so much for taking the time. Long weekend. And speaking of that, as some of you might know, the Winds of Change event took place over the weekend, and it brought together many great speakers and experts. Both Dr. Newaz and Girl Jaw were there, with Dr. Newaz presenting. So let's talk about all that valuable insight shared at the event, and then, as always, we'll have a live Q&A where everyone can pick your brain. So to kick things off, I'm going to give the floor to Girl Jaw, brief us in on the event, and just have a normal conversation.
Yeah, I'll take it away. So I also just got back from the Winds of Change event. It was held in Chicago, Illinois this year. I learned that there's actually been previous ones. I thought this was the first one. So what's cool is they're also doing it next year. So they've already preemptively scheduled it in Berkeley, California, which is awesome for this Californian because it gives me an excuse to go to another one because it's not so far away. But it's put on by, or at least this year's event. I don't know if Dr. Newaz, do you know if they're all put on by Dr. Mandelaris and Dr. Movahead?
Yes. Yeah,
okay.
They are. Yeah.
So a periodontist in Chicago, Dr. George Mandelaris, I've made content about him on my channel. And then in St. Louis is where he's mainly based, is Dr. Reza Movahead, who is an oral facial maxillary. How do you say it? OMFS, oral maxillofacial surgeon. There we go. So together they brought a huge team of airway. So the reason it's called Winds of Change, right, is they put together an event where it's interdisciplinary, which is kind of the topic that I've been researching lately with my content. Is should expansion, at least palatal expansion, be an interdisciplinary approach? And Dr. Mandelaris and Movahead definitely brought together a lot of key players in different fields who are all very passionate and work in their own segments of airway and airway health. So Dr. Newaz was actually a speaker there, so a guest lecturer. So Dr. Newaz, your lecture started off as maxillary expansion and FME experience. But then by the time you lectured, you changed the title. And I'm curious if you can explain a little bit more on why that title changed and what it changed to.
So we changed the title to, like Rethinking Expansion, kind of like the state of expansion today. I thought it was a better representation of, some of why the field is headed the way it's headed, and what are some of the things that the field is going to have to contend with if we intend to move forward responsibly and excellently. So that's kind of, I wanted to sort of touch on that and give like kind of a quick 2-minute history, and then just jump into, kind of where we landed, with respect to that conversation. And just kind of talk a little bit about some of the questions that we need to be asking in this subdiscipline.
What are some of those questions?
Well, yeah, I mean, there are questions about like some of the more obvious questions center around, like device behavior and, device evolution, protocol evolution and things of that nature. And then, kind of further, kind of next dimension of discussion includes the context of expansion as it relates to interdisciplinary treatment, as well as, understanding, the head as a movable three-dimensional object in space, and what, certain common relationship, perspectives we need to consider with respect to the C-spine, the sphenoid bone, the skull base, all of that. And I think a little bit more deep abstract topics about expansion.
Yeah, so I was in the cadaver lab when on Saturday when Dr. Brad, I think Gilden spoke. Were you there for that lecture?
I was.
Yeah, and so I know that the lecture was about connecting posture to airway. Did that address any of that body alignment that you're speaking of right now?
Yeah, absolutely. And, I work directly with Brad, as you now know. So that, I'm fortunate really to have his perspective and, have been able to collaborate with him on several patients where we can actually see this played out in real time. Patients who are getting support from, kind of the whole body dimension and doing expansion concurrently, or perhaps better preparing them for expansion.
Yeah, where is he based out of? Let's see if I
New York and Greenwich, Connecticut.
Okay.
Yeah.
Yeah, very interesting. So I'm like, can I work with him? But he's far. But essentially, like what I'm doing then in preparation for my next FME, working with some PRI people, my PT, my chiropractors, all in theory setting me up for a better experience second time around. Am I understanding this correctly?
Say that one more time.
So, because following a body postural regimen pre fourth expander, right? I'm on like a fourth total in my lifetime expander. That's setting me up for better success. Like, is that the trajectory that this is putting me on?
I think that's the idea.
Okay.
That's the idea. I think for most individuals, they stand to benefit from that type of work. It's not that necessarily every single expansion patient needs to be pre-prepared in the, sort of postural therapy realm, but it is a very valuable thing for individuals who may have observable, asymmetries and also craniocervical deviations from totally upright and normal, right?
Yeah, so people like me.
Mm-hmm.
So people with pre-existing asymmetries. Okay.
And not just people with pre-existing asymmetries, also people with, who may be symmetric, so to speak, but have a lot of downstream postural compensations as a result of problems that they have either in the cranium or the TMJ or the craniocervical junction or the skull base.
So living with pain would be one indicator?
Living with pain would definitely be one indicator.
Okay.
Right.
Okay.
Especially because nociceptive input or pain is often something that I think correlates pretty well with the body's nervous system taking more of a, kind of a guarding type of reflex to structural changes, right?
Mhm.
If somebody's living with chronic pain, they're, certain aspects of their nociceptive input are upregulated, right? So that is undoubtedly a consideration for somebody undergoing orthopedic expansion of the midface.
Yeah. Absolutely. You mentioned during your lecture that with you and Dr. Jafari have 170 plus completed or I should say FME cases. Little sound effect if I had one. Like, yay. Curious because I fully don't understand the difference between what I had, the 3.5 and the 4.5, and then the upcoming Pro. So what are specifically the differences between all of those? And maybe more so the 4.5.
The 4.5 and the Pro. I think the most notable difference is, at least readily observable difference is the presence of the expander module having side flanges.
So what are the side flanges?
So the side flanges, think of, like a lid on a box, right? For that lid, I mean, imagine that lid was just sliding on the box, right?
Okay.
It was just situating itself over the box. That's your 4.5. And then imagine that it can actually grab the sides and click down, right? That's your Pro, right? What the side flanges do is that they resist and counteract the force generated within the anchor bodies to have a tendency to fan out towards the inferior, right? Basically, you're going to have resistance superiorly, right? Your maxilla is, of course, a very resistant structure, right? And so when you have resistance, not your maxilla, but a maxilla has, there you go, right? You could kind of see those little side projections there that show you that.
Are we talking about up here or down here?
Up there. Well, you can kind of see it down there too.
Like those little things sticking out.
Those little projection thingies. Right? Okay. So what those serve to do is basically brace the anchor bodies, which are the substructures underneath that
down here
that then have the TADs that go in the palate, right?
Right.
And those, because your palate has more resistance than basically the activations in the device, then that device is going to tend to tip out towards the bottom. Well, let's say you have a nice cap on there and the whole force system has a lot of vector control and rigidity in it. It is going to resist the anchor body's tendency to do that, which is kind of known to correlate with failure if that advances too far. And then, there becomes too much resistance, tension, friction built up in the expander.
So is this mostly seen with people with really dense bone? Like that this happens?
It's most commonly seen in individuals with very dense bone. But
it can happen with anyone. I see. Okay, so the only difference really between 3.5 and 4.5 is just that angled anterior TADs, or was something else added?
4.5 has, and Pro of course has some more items that we can talk about, but 3.5 to 4.5 was, so one of those things was the lid, right? So now imagine, you're, you kind of have this overlaid, kind of structure over the anchor bodies, whereas the 3.5's expander would totally nest inside the
I remember that. I only have this part, but yeah.
There you go.
This thing.
So imagine that thing totally rests within,
right?
The height of the flanges, right? Yes. The 4.5 kind of has a lid that just sort of overlays.
So does that make it thicker as far as its height?
It does essentially make it thicker.
Good
the
to know.
4.5 also has a little bit more of an aggressive taper in its body design, so as to be able to better nest superiorly in narrower palates, right? Of course, distance to the tissue and the palate is a known variable modulating the success of expansion. And then you also have your...
Was that created with narrow or high vaulted palates in mind because the FME 3.5 was hard to fit in? Okay. Got it. Continue.
And then, of course, you have your oblique TADs. Those are in the first two rows in a 4.5, right, where the TADs diverge, superiorly. And it has a thicker jack screw, right?
Thicker,
so the actual...
so like my baby one here, you're saying this guy? is thicker?
Yeah, the actual center bar of that is the jack screw,
Okay.
right? So imagine that with a, larger diameter. Yeah.
Gotcha. Was that stripping? I remember some people telling me the FME got hard to churn. So,
Oh, well, the actual hex nut that is the center of that jack screw would sometimes strip. And that's actually, I
I
mean,
see.
that's a problem regardless of,
Of
the 3.5,
expander.
4.5. It's not that the 3.5 necessarily stripped more, but of course, the strip tolerance, I guess, is different between the two. But both can wear out, right? If you're applying large amounts of force and basically the little, activation key or the wrench is kind of grabbing and maybe slipping a little bit as you try to turn that hex nut, then basically what it does is it applies too much pressure to the edges of your hexagon and wears out the corners. If it wears out the corners, then it makes it progressively harder to grip and turn.
Yeah. And which is a problem with MARPE too, because I hear that all the time.
Correct. Yep. It's from universally.
Yeah.
Yeah.
So you were saying something that there's more differences with the Pro. Will you touch on that quickly?
Yeah, the Pro, so the Pro basically also, it has some different, housing designs with that just kind of make some of the, the guide rods and the jack screws sit a little tighter
Okay.
inside, that the whole apparatus, and then also more oblique TAD rows are available too, right? So you
For
have
all the
oblique
rows.
anchorage for all rows,
I
right?
see.
Which also is very helpful for septum avoidance purposes, right? A lot of people do have a, somewhat undulating septal base attachment. And so the divergence of the TADs helps you avoid that, plus engage more composite bone surface area.
Right. Which I learned in your talk that you actually had the septal divergence.
Yeah. Oh, well, because I didn't have septal divergence because I
Or
had a
yeah.
3.5,
Sorry.
I had partial engagement of the
That's what I
septal
meant.
base. And of course,
Yeah.
it was clinically insignificant, but you could definitely see that it did have a mechanical effect
It
on
moved
the expansion.
So are you planning to get that fixed with an ENT or?
I don't think I need to. I mean, functionally, I feel pretty well balanced with the pressure gradient. I was so restricted that I just needed more real estate on both sides, and that's exactly what I got.
And I know I ask you every time I see you, but how's your breathing?
Yeah, no, I mean, breathing is great. Daytime nasal breathing is fantastic. I still have, some work to do with bite coordination and, of course, anterior posterior. And that's even with me having gotten, of course, a lot of viewers of this, channel will know that I got, pretty remarkable protraction just as a result of my expansion. But I'm so recessed, right? I mean, I'm a prior, patient of premolar extraction and this and that, and whatever headgear class, class 2 mechanics, holding the upper jaw back. And because of that, right? I mean, I was super, bimaxillary retrusive, especially with respect to the airway. I facially camouflage it a little bit. I don't necessarily look outwardly so bimax retrusive.
So like
but,
facially camouflage it with your nice beard?
that's what I'm talking about.
Pretty
Yeah.
awesome.
So the
Guys, you have that
facial hair
advantage.
will definitely help camouflage that. They actually showed a very remarkable example of that at the conference. Were you there, or you might have been
Which day was it?
slicing up your cadavers? That might have been the second day.
Yeah,
Um,
second and third day I was mostly in the cadaver lab, so I missed a lot of those lectures. Yeah.
Yeah, they showed somebody who, pretty much had a normal looking, sort of jawline and chin projection. They shaved the facial hair off, and it was basically like, no chin.
Tricky. They say
Yeah,
a beard is a man's makeup. I
there
don't know
you
if you know
go.
that, but yeah.
Yeah, so, so basically, I think that's where I think for me, translation into sleep, where I did get, observable benefit was, continuity and yield of sleep. And I can say this as somebody who often gets poor, sort of quantity of sleep, right? Or irregular, right? I'm not one of those people that really regulates my circadian rhythms very well. My lifestyle simply doesn't allow for it. So I've, made a career out of functioning, within my own parameters. And I do okay with that. I do a lot better with disruption in that than I think the average person. I think we're conditioned to do that by necessity. But I know that I can use improvements. I can use improvements with my own sleep cycle and habits, and I can certainly use improvements with my jaw behavior during sleep. And right now, just at this particular time, the amount of arch discoordination I have between upper and lower, I think, is a contributor to the jaw being really kind of wild and active.
Yeah.
So I think my sleep-related bruxism has temporarily, transiently increased, right? But of course, we're gonna fix that. So
Yeah, and that's common. So like that's common
yeah.
feedback that I hear from patients who reach out to me or post in the Facebook group, essentially constantly saying, "Did your bruxism get worse with expansion, or is your nighttime grinding worse?" And like, yeah, the instability during expansion for whatever reason does lead to that extra clenching.
Mhm.
So I love my retainer, my plastic like Invisalign retainer, because it works as a night guard for me. Otherwise, I'm certain, I think I told you this at the conference, that I would probably be grinding my teeth away at this point because my bite is so unstable. But I wanted to ask you a question because you did show me your arch discrepancy at the conference, so you're pretty expanded up top. What are you considering for your bottom? And I know that this was discussed during the conference of like what options there are for mandibular expansion, and SFOT was discussed, but not fully in that realm. And then MSDO was both discussed and shown in the cadaver lab. So I'm curious what you're going to do, what your options are for your case.
Yeah, absolutely. I mean, I have a practicality bottleneck with getting everything I would ideally need to get. So I do intend to get some of those idealizing kind of procedures, namely MSDO, perhaps supported with at least some partial bone augmentation in the anterior ridge of my very thin mandibular alveolus
And
anteriorly, right?
and for those that don't know, that bone augmentation is SFOT. It's the same thing.
Correct.
Yeah.
Correct. So I definitely want to try skeletal expansion of the mandible. I think I'm classically a good candidate for it. I probably wouldn't have been maybe the most ideal candidate for it in my pre-expanded state, just because not just from transverse discrepancy purposes, but just from a perspective of where the TMJs originated at full closure, right? I had very little forgiveness, mediolaterally in the fossa, and also definitely posteriorly. I was pretty jammed, right? And for the viewers, what that means is, right, the head of the jawbone or the condyle sits in the socket, right? And, we assess its position, right? We want to see, what are the issues with the spatial relationship between those bones. Is it too high up? Is it too far back? Is it too far forward? Are there other space constraints related to the slope and architecture of the fossa as it relates to being a healthy housing for a condyle that may be shaped a certain way, right? So for me, as somebody who's very posterior displaced and with very little mediolateral freedom of the condyle, right? For me, that was definitely, that would on paper be something that would, offer some pause in considering candidacy for MSDO. But now that I've, gained some clearance anteriorly because of my expansion, and I intend to gain a little more ventrally, with how I manage the upper anterior segment orthodontically, right, where I can afford to maybe torque those teeth out a little bit, maybe advance them just a tiny bit. I have a lot of clearance now. And with that clearance, my mandible is muscularly able to achieve a pretty neutral position where it walks into some bit of that clearance. And because of that, where it then results, right, which we showed with the CBCT scan, is a little bit more of a decompressed position. Now I have quite a bit more of a neutral TMJ position. And, people's condylar positions, are better characterized by a range of allowance rather than a specific point or target position. And so I think I have range now that I've gained some clearance, from my posterior compression. I think I have some allowability now for the types of rotational and lateral changes that happen in the condyles with MSDO. All of that theory being said, what I'm going to do in the immediate term is I'm going to get a lower Hyrax expander, right? Just a lower fixed dental expander. I have quite a bit of dental uprighting to achieve.
So and just to clarify, that's not going to expand the bone. That's only to upright the teeth. So it's like
in the posterior segment specifically,
okay.
Right? So we're going to upright the teeth in the posterior segment. I'm going to gain some arch width. That will help reduce the level of discoordination between the arches transversely, side to side. And then it'll give me some room to uncrowd the anterior teeth, canine to canine, right? So I'm going to probably get in there with some braces just for a little bit with my fixed expander, activate it very slowly, 1 or 2 turns a week probably. And I'll probably do 2 because I kind of want to. And I think I can tolerate it. And I kind of want to gain some, I've been living with this discrepancy for quite a while, right? So I'm excited to try to get it a little bit more coordinated. And I also have certain luxuries in my own contemplation of my own sequence and treatment that many understandably don't have. I could easily, let's say if I suffer a little bit of non-ideal periodontal consequences, well, I know who to holler at.
Dr. Mandelaris in Chicago.
Yeah, buddy.
Can you tell me what the benefit is of using an expander, like a tooth-borne expander to upright the lowers instead of braces?
Yeah, no, great question. I mean, braces alone could do it with the right arch wires, with the right mechanics, maybe some cross elastics. But I think my upper teeth are in a normalized enough inclination, right? If my upper posterior teeth were very flared, I might want to use them as leverage to then upright the lowers through, let's say, lingual buttons and cross elastics, right?
Yeah.
Putting an attachment on the inside of the tooth, hooking it up to a rubber band to the outside of the tooth, so you get a little bit of reciprocal, mediolateral type of movement.
But who wants all those elastics in their mouth?
Well, elastics actually, and that's a great question, because even though they're a pain in the ass, they can also feel very stabilizing, right? For somebody with a, very mobile jaw, unstable bite, right? Kind of helps ground you a little bit if you set up your pattern according to what that patient needs, right? And then, so what I'm going to do is, I'm just going to do some gentle, orthodontic uprighting with the support of a lower expander. And of course, a big part of my journey is understanding, kind of what it entails to actually do a lot of these things. So I think by the time I'm done, I may have ended up doing, an expander, lower skeletal expansion, SFOT, just a lower dental expander, and braces and aligners, right?
So the whole gamut,
full complement of modules, of treatment that we offer.
Well, you'll be really empathetic to all of your patients. Then you'll know what they're going through.
So that's kind of what we're going for, right? I mean, it's always, and you begin to appreciate some of the subtleties of small issues, small nagging issues, or small wins too. And you can see, wow, that tiny little thing made me, 20% more comfortable. Wow. That's pretty cool. And just a quick point on other modules of treatment, right? I've also tried in orthotics, right? So I've worn a lower orthotic that has helped.
Is that like a bite splint or something?
Like a bite splint type of thing, right? On the lower arch, that kind of helps, serve as a buffer to artificially produce some, bite stabilization and support, where I'm otherwise trying to migrate my teeth to go to that position. But it was helpful to try that as well. And that's one very simple intervention that helps a lot of patients, especially to calm down the nervous system. Why do I, and all this splash about the nervous system is really to understand that, there are small nervous system agitations that can happen from non-ideal jaw positioning that we can uncouple relatively, quickly and easily, either through splints and orthotics or essentially fixed, auxiliaries on the teeth, like
Like my
bite
bite
turbs,
ramp?
like
Huh.
your bite ramps, right?
Yeah.
And they can have directionality in them that can help, position the jaw a little closer to where you want it to go, which helps retrain musculature. It helps deprogram musculature. And it helps also maybe offload stress in areas where you're not putting it, and it helps maybe introduce otherwise wanted contact or stress to areas that don't have enough of it. So it's a valuable tool in the treatment of a complex orthodontic patient.
Yeah. Makes me wonder if I should bust out my, can't remember what it's called, but I had that anterior bite ramp retainer. Do you remember what those are called? It was like somebody's name, Smith. I don't know, but I had it before FME, and I'm like, should I bust it out again? Because that actually really stabilized my jaw because I
Mm-hmm.
wore it at night.
Mm-hmm.
And yeah, I don't have one of those. Doc, help.
Well, again, this is a static medium, right? Everything in your case is perhaps dynamic. Now, until you make more tangible decisions on what you want to do next, that would be a reasonable thing to do, right?
Yeah,
Stabilize you in a
yeah,
static medium, right? But that's also another consideration in treatment, right? Of course, a lot of therapeutic types of appliances like splints, orthotics, bite plates, sleep appliances, this, that, whatever, you name it, right? There's a lot of things that have a therapeutic value, but depend on the teeth being in that same position,
yeah.
and harmonizing that with trying to be dynamic and move things around at the same time can be
Gets
difficult.
complicated. Yeah,
It can be
exactly.
complicated. So, and sometimes it makes sense to pause dynamic stuff to, allow static stabilization and resume dynamic. Maybe you're doing static in one arch and dynamic in another arch, and so forth, right? So, or you're trying your best to couple them together by using things like auxiliaries, right? Little bite ramps and turbos and other things that serve, that can coexist on a moving medium that will, of course, need incremental adjustment from time to time.
Yeah, absolutely. As I've experienced. Patrick, I just want to check in. Did we want to move to the Q&A, or do we have more time to ask a few more questions?
I think we have more time. Like
Okay.
I'd say 5 minutes, and then we can switch over to the questions. We have a handful of questions, so
Okay, sweet. So let me pick your brain about MASP, right? Because that's the new buzzword. It was mentioned at the lectures.
Mhm.
I think Dr. Claire Ferrari maybe discussed this a little bit. And then I heard all the orthos chime in, like, yes, we are all doing MASP. We just don't call it that. We just still call it MARPE. But I remember you discussing with the FME why slow is helpful, especially for disarticulation or like bilateral disarticulation of the sutures at the same time. So I was just wondering if you could explain, how your practice essentially does use MASP, a slower turning protocol, why that is beneficial, where it may not be beneficial, et cetera, et cetera.
Mhm. Great question. And I think actually, I think there's a little bit of sweet spot determination that is still, I think if we're being fully diligent about it, I don't think we actually have perfect answers to these questions. But what most of us who have a lot of experience with expansion have settled on is kind of like a reasonably moderate and, gentle pace that allows for dissipation of the force generated per expander activation before the next one, right? And typically we see in most, adults who we try to expand that takes, a few days. Maybe we are trying to outpace that in the very beginning to produce a split and take advantage of other bone release conditions that we have introduced to facilitate expansion. But maybe after we've achieved that, then we try to then, go to a slower than what the patient needs kind of a protocol to propagate the expansion, right? We are now carrying your expansion, a little bit more predictably by going a little bit slower. But then even in that milieu, there's such a thing as too slow, right? There's such a thing as, reintroduction of resistances and healing and, tethering and all these things, so unless you're doing other accessory things to keep those sutures nimble, so to speak, that can actually work against you as well. So there's some sweet spot determination. I don't suspect, it's going to be much of a question once you feed, like a modeling program, like a ton of CBCTs and just kind of produce some results about when certain sutures are just articulating with respect to unit activation and somebody's native bone resistance and thickness and other, variables that might describe how resistant someone might be to expansion.
So are you going to invent that software?
I mean, I sure hope so. I hope I have something to do with it. I don't think I'm smart enough to do that, but I would hope to work
get
with
Patrick
people
and
that
JP
are.
involved. Yeah.
Yeah, buddy.
And get some AI research program, which can help the future of expansion. Because essentially that's where your talk led us to, right? Was what is essentially the future? Where are we going with this? Where we've come from, where we're currently at. Where do you expect your practice to be in a couple of years, 5 years?
Yeah, buddy. That's a great question. I'm not sure. I think that's honestly a very good question. I think there's a lot of field related answers I could give to that question. Then there are personal related answers I could give to that question. And I think that maybe those two things, we'll see how much they relate, with time. But I hope to have a role eventually, perhaps in a time frame like that, where I will have a little bit more opportunity to invest, time, energy, money into understanding this stuff better and helping build a better future for the expansion community. That's really what I think I should be doing, given what I've learned as a clinician. And I obviously want to continue learning as a clinician. But, in some ways, I consider myself a diagnostician first and a clinician second. I think that is what may inspire, me to take, tangential detours on my career.
Well, I guess your future depends on how well you can qualify. Is that how you'd say it? How well you can get the quality of your sleep under control.
Yes, that would probably help to some degree. Yeah, I mean, I'd love to see, I'd love to see how I continue to do with just small incremental improvements, starting with, of course, a little more arch coordination, then going into other augmentation. And then, I'm kind of keeping an open mind to things like jaw surgery and so forth. But it's just, it's almost situationally prohibitive. For someone in my situation, I just have too much, too much day-to-day dependence.
Oh, Dr. Newaz.
So, well, I might have to wait, but we'll see. Yeah, exactly.
I'll sleep in 5 years.
That's if I even make it to 40 at this point.
No, you will. If you don't, I'm gonna replay this at your funeral. Be like, this
You should.
MFer cursed himself in 2026.
Oh no. But yeah, I think it's so it's interesting. I if you asked me 5 years ago if this is where I'd be today, I probably wouldn't, I'd probably be way off with what I'd predict for myself.
But literally same. And Patrick, how about for you? Same. Would you think you'd be running like the world's best expansion directory?
That is the goal. And making
5
a
years
difference.
ago, did you think that you'd be doing this?
I think so. Yeah.
Okay. 5 years ago you did? I didn't 5 years
No,
ago.
no, not 5 years ago. Sorry, this is very recent for
Yeah,
me.
yeah.
If JP was here, he'd tell you otherwise. This is like his dream. So
Well, I hope I get to meet him too.
yeah. Eventually. See, JP, I'll just talk on his behalf without mentioning too much about it because he likes to stay behind the scenes, but he really wants to get treatment. That's his end goal. He's very big on this. So he'll be a huge advocate. I think it's gonna be part of this whole thing.
I know it is pretty wild how it is an epidemic, right? I mean, just like Dr. Newaz, Patrick, me, we see all these people who have these sleep and airway complications, and it's impacting our life greatly, for years and years and years. And it's just wild.
Yeah.
I know that it was discussed at the Winds of Change conference. Can't remember who it was, but essentially linked to diet, right? Is that your understanding, Dr. Newaz? Is like the diet, the soft foods diet, the industrial revolution, and like civilization is just totally impacted our craniofacial development, jaw.
Absolutely. Yeah. I mean, we've faced a lot of headwinds as a species, I think, in terms of jaw development. And there's just so many, there's so many artificial, things in our environment that, we just haven't really, I mean, it's a lot for, a species and a system to adapt to. And so I certainly think that is part of it. Do I think that there are answers to, mitigate the effects of that? Absolutely. Right. That's in part why we're here. It would be great if we didn't have to be here, but we are nonetheless in a position where we have to be here to, help, kind of soften the blow that we get from our environment.
Yeah, and I guess like now with all of the awareness, you have all the parents like Ron, for instance, who are going to have their kids grow up like very aware of their myo habits, their oral habits, and we get to see the continuation of that down the road and then see like, does that help? Is that the thing that we all aren't doing? Or is there more to it? But I highly suspect that's a huge, huge part of it all. Probably not the only part, but a huge part. So let's get right to it. Is there a release date for FMA?
There is not a release date for FMA. There is definitely progress on the retooling of FMA, and I know that progress is tangible, but I know it's not quite at the stage where we can receive from the company nor give any guidance to the community as far as its release date. So we have now made a little subspecialty in our own practice of, showing people other ways that they can protract in the interim, because FMA is just simply not an option right now. And it's a wish, I think, of the engineers and really us, if we're going to give this to patients, to know that it can be maybe a little bit more, sturdy, a little more predictable. And those are the very things that are being retooled in it. It's, you know what I mean? So as far as a force application system, very impressive. As far as, for the little bit that I tried it, right, a few minutes or whatever of composite wear time, I mean, you can definitely feel that it, protracts the midface and would be pretty effective at doing it. But there are just some practicality, user experience kind of things to iron out with that. And with as meticulous, I think, as they are being about this, they understand, I think, the, how much interest there is in it. I think they want to execute it well. And I think they're taking the initial feedback from myself and the other patient that used it to better design it. But that's where it's at.
Question of my own to insert into this, because I am not a medical device like provider or lawyer of these types of things. I say lawyer because my understanding actually is, okay, first let me ask the question, is Facegenics making this protraction device for adults?
Yes.
Is that how it will be released?
I mean, that's the presumption. I would think so.
Because my understanding, right, is that the face mask and the bow and the crane, those were all child protraction headgears, correct?
Well, the reason I'm sounding ambiguously unsure about this is that I've actually never thought of it not to be. So this is the first time that's actually been presented to me as a question. I think the assumption is that this is basically supposed to be a facial protraction system almost specifically for adults, but certainly not exclusively for adults.
So then I bought the crane, right, as a lot of you guys know, to prepare for like maybe my next expander using that. And I was like, well, to my husband, I'm like, why don't we just invent one and sell it since this is off the market? And he's like, well, let me tell you all the reasons why not. And so it has to be approved by the FDA if it's a medical appliance. And apparently dental appliances are, orthodontic appliances are. And so he looked up the track record of the crane and then essentially told me that all protraction headgears in his quick, search are for children. And because the FDA has approved it, because there have been studies of efficacy and failures and complications. And if you were to invent one for adults, you would have to be the first, and therefore pave the way with studies of efficacy and complications. And so I wonder if Facegenics is going that route, that is also an obstacle that they are up against, because they're going to have to be the first to provide all this data. And then to me, that means that that's going to be another barrier for all of us waiting patients to get the FMA.
Yeah, I can say that the company is certainly conscientious of regulatory headwinds and does consider that and that's why you would kind of think like everybody and their mom wants FME and FMA. Like, why aren't they giving this to more, doctors and more patients and just coming out with it and just giving it to us? Oh, like, if I agree to be a test subject, right, will they, I saw a question to that effect, right, will they give me one? Right. And I think their hesitancy, with that is probably this.
Yeah, because I think that they'd be liable. Not think, right? I guess they would if with any medical gear.
Well, now, and I can't speak to the allowabilities for a novel device to have to, pass through those rigors and in what way to be tested. Of course, if something is novel, what procedure exists to allow its, rollout. That's something that I don't really have expertise on. But maybe a question.
Correct. Yeah. And that's why I said, I'm no expert either, but these considerations were like a light bulb as to, there are a lot of hoops that Facegenics definitely has to possibly jump through for being innovators, in the adult expansion game. But so, okay, let's move on then to the next FMA question, which is, did the preliminary patient that tried FMA get protraction?
I don't think so, because they weren't, again, able to utilize it for long enough to produce that effect. Right.
Are you that patient?
I'm not that patient.
Okay.
No. This patient tried it even better than I tried. Okay. So I actually gave my FMA gear to them so they could use their custom made wire or whatever to hook it up onto the apparatus and try to get protraction. And I think they gave it a fair shot, but they just, there were too many, I think, ergonomic related issues with it. So that's why it's being retooled.
Yeah. It's so for being a patient who's tried the bow, which is like I would say a a more compact version of what I've seen the FMA to be. The bow is hard to wear. So I really feel like FMA would be crazy. It would almost be like prepping for us like a skydiving jump, you know, every time you put it on. You're like, because didn't you say it was a harness you essentially had to put on and like strap
Yeah,
on?
pretty much. Yeah.
It's pretty cumbersome. I mean, I get that they just invented it, right? So they're of course refining with all the feedback. But I see the, I should say like the pros of that, because it's going to fit snug. Where the bow that I had, you know, it's just like a strap that kept it on the chest and it moved around a lot. But then I can also see the setbacks of patients actually wearing it. Yeah, so sounds fun.
Yeah, buddy.
Somebody asks, Dr. Newaz, how happy are you with the expansion? And would you be happy with the results if you only did like 5 or 6 millimeters? Or did you need the extra few millimeters? I think they're probably talking about your like Brody bite.
Yeah, for sure. I mean, again, I feel so confident that this Brody bite is not, you know, unfixable. I mean, you know what I mean? Like this in my view is a easy Brody bite. It's not even full Brody. Okay. It's like partial, right? It's just buccal cusp, you know, of the lowers on the lingual cusp of the upper kind of thing.
So what's the difference with a full Brody? Are you actually off?
Yeah,
completely?
off.
Okay.
Yeah, I'm not off.
So you're still
right?
hanging on by cusp.
I am. I'm hanging
Okay.
on by a cusp. Yes, I would have been satisfied at 5-6 millimeters. I think my expansion, you know, I wouldn't necessarily say I mean, well, I'll answer this question in a layered fashion. You know, I probably, at least subjectively, had very similar benefits at 5 or 6 than I do at 9, right? That being said, intangibly, are there things that may be better just from a sleep and oxygen reception standpoint with the fact that I have more? Have I set myself up for a better situation? You know, of course, provided that other aspects of, you know, the arches coordinating and this and that can be achieved. You know, I think that there's reason to contemplate on that issue, right? That, you know, there's certain gains that, you know, subjectively, you know, maybe after a certain point, it may be diminishing returns, but maybe in the grand scheme of things and reducing resistance to airflow, there may be a value in chasing a little bit more, but then it also could be counterproductive to chase a little bit more, because then you start messing with, well, and again, this is aesthetic and, you know, asymmetric expansion kind of related risks aside, you start introducing specifically nasally and airflow wise, you can produce an environment where pressure gradients, you know, get compromised. You could, you know, introduce, you know, kind of air hunger type of things. That's kind of like a bell curve, right? You know, there's a sweet spot for turbulence and resistance to airflow. And you know what I mean? Like if you were to spit a spitball through a regular drinking straw, it will travel. If you try to, you know, spit a spitball through a coffee stir, you can't produce enough air in the tunnel.
Right.
But if you try to spit a spitball through a paper towel holder, you're also going to have a problem, right? So, you know, airflow dynamics and velocity as a function of resistance has to be respected. So it's not necessarily the more the better. But for me, right, I mean, right now I'm at like a 41 millimeter intermolar width or something like that. Like that for me is pretty good. I mean, it's still, I feel like I could probably use a little bit more.
Your goals for a lot of us.
What's that?
You said your goals for a lot of us. That'd be nice to have 41.
Yeah, you know, I think, and again, this work is so highly individualized that I think like the worst thing I can do as a doctor is project what I want for myself onto my patients, right? I mean,
Yeah,
you know,
of
that's
course.
not really what we're trying to do. Obviously, I wanted to mess with higher amounts of expansion so that I could see maybe what, you know, good and bad comes of it, right? Again, I live in a world where I have luxuries to remediate these things.
Be your own guinea pig.
Yeah, exactly.
Well, thanks for taking one for the team
Yeah,
and
buddy.
figuring some stuff out. Well, so let me jump to Patrick, number 8 question, which is somebody's asking how much wider is the maxilla supposed to be than the mandible?
Great question. I think this is actually a somewhat fluid answer. I think your standard, is your kind of 4 or 5 millimeters, perhaps. I think there's a little bit of allowability there, depending on how much compensation or decompensation you can have. So, I don't necessarily, I don't consider myself too rigid with that particular metric, but I do look at it. But that's kind of conventionally.
It's like 4 to 5 millimeters wider upper than the lower. When you say compression, decompression, are you talking about just uprighting everything first? Is that what decompression means?
No, usually when I say the word decompression, I'm talking about now that's decompensation.
Oh,
Decompensation is different than decompression.
okay. And you said
Okay.
decompression, right?
No, I said decompensation.
Okay. So is
Sure,
that
at
what
least
you
I
mean?
hope I said decompensation because that's what we're talking about now. So
Okay.
so we have, basically in a lot of narrow palate individuals, the teeth are compensated, right? Lower teeth might be tipped inward and upper teeth might actually flare outward, right? And in deficient maxillas, we often see posterior molars, particularly second molars in a very maxillary deficient case, right? They're like really fanning out, right? And so those are very compensated molars, right? In part trying their best to sit outside the lowers, and the lowers are trying their best to squeeze themselves to fit inside the upper, right? Teeth are very good at doing that as a response to certain skeletal growth patterns and
Right, which is why a lot
disharmony.
of people's lower teeth can be uprighted if they have a narrow palate.
Correct.
Got
Correct.
it. Okay. Wow, that's that like light bulb.
Decompression, I'm usually referring to spatial relationships in the TMJs.
Okay, yeah, and how they sit. So if they're like here, is that compressed? And then you would kind of decompress it like that. Is that
Yeah.
okay? Yeah, I didn't realize decompensation was just the D of the compensation. I didn't realize, right? Because our teeth compensate for whatever our bite or everything functionally has been doing. Okay, next question. Do you know when FME will be offered by more providers?
No, I think it's actively growing. That cohort is growing, every month or two. I think there's like 1 or 2 new ones. Again, they vet these providers for, I think, a certain level of competence and, comfort with this thing. And, and maybe in terms of, I mean, they like experienced providers. They like people who understand expansion and perhaps are philosophically somewhat aligned with the potential merits of this expander. And by merits, I don't mean superiorities. I just mean like, hey, does somebody maybe understand that there might be a utility to having access to an expander that behaves like an FME, right?
Yeah.
And I think, with that and with increased, kind of anecdotal support for its efficacy, I think you're going to quickly see a lot more providers, right?
That's cool though
There
to
is a
know that they're
barrier in
vetted.
terms of, say that again?
It's cool knowing that like Facegenics considers like a vetting process for it, that they're
Yeah,
not handing it out, that they
correct.
actually want people to take their product seriously, it sounds
They
like.
do.
Yeah. Sorry, I interrupted you. What were you gonna say?
No, I mean, I was just going to say that, I mean, of course, with just as much experience as we've had with it and, generally very positive types of, reception and results, I think that is kind of the cornerstone for this thing being able to, really pop off. So yeah, so we'll see. I think that there's, we of course independently are trying to study some of its effects more empirically, right, and academically in the research realm, right? And so we think that that may be something that also helps open up some room for acceptance and adoption, widespread adoption. But we came to the field first, and we've done a lot of these. We put a lot of thought into it. You know, a lot of the design changes and iterations you see are direct results of our experiences with it and conversations with their engineers to help inspire certain designs, right? You know, I'm not taking credit for all of those changes, but certainly, you know, of course, you know, we have just so much to report back to them about how patients are doing, and we've definitely seen, you know, we've seen them take that feedback very seriously, and we see a lot of those changes very directly reflected in some of these iterations.
Yeah, yeah, buddy. So you said first to the field, you meant like first to FME, right?
Well,
And
yeah, I mean, I'm not technically first. There were a
who
few
was?
FMEs put in. Huh?
Who did it? Because I
Dr. Ting did it before I did.
did he do it on a fellow colleague or did he do it on a patient?
I actually don't know. I
Okay.
don't. I understand that there might have been a small cohort of patients with the preliminary, um, you know, like generation
Okay.
of the FME.
But then he said,
Um,
"Nah."
you know, honestly, I don't know really what went behind that. I think for whatever reason, you
And
know,
this was the first
it
iteration, right?
that was the first
Okay.
iteration. We weren't really in the picture at that time. When that second generation was being designed and came out, and I happened to have, you know, patients that were asking me for it, and I had, you know, reached out to the company to try to, you know, basically learn about it and, you know, start to offer it. That's kind of how it started for us. I wasn't actually really aware at the time what the peripheral landscape was with respect to other providers doing it. It just later became very apparent that it was just us. And then soon after that, you know, of course, you had a couple other very smart and talented individuals join that cohort. Um, and um, and you know, now there's a small group of providers out there doing it. You know, and all of them, I think, have shown a lot of you know, good sort of competency with their understanding of expansion. And you know, and just, you know, I mean, as you can tell with this comment, I'm not here to, you know what I mean, like we're here to lift other people up. We're here to lift a whole community up. I'm not in the business of trying to say that, you know, I'm better than anyone else, because I'm not. But you know, we ask, you know what I mean, like we ask for, you know, I guess, you know, some sort of guidance, you know, from above to continue to do good work in this field. And that's kind of, well, all we're trying to do.
Yeah, it's cool. So it sounds like you were one of the first providers to really adopt and welcome like what Facegenics was doing and really take it and run, especially when you had a community who kind of were very well informed and then it just so enthusiastic about what Facegenics was providing.
Hmm.
Yeah, and then like, those two things just met and went, and then here
Yep.
we are. Taylor
Yeah.
about to get her second FME probably.
There you go.
Taylor, aka Girl Ja. All right. So next question is, how successful have your UARS patients been with FME?
Great question. You know, UARS is it's definitely tricky because, you know, objective you know, methods of, you know, actually you know, kind of diagnostically seeing how a patient has responded are not necessarily, you know, there for uniform and easy access. But what we can say is that a lot of the symptoms and the symptom patterns that come with UARS have generally measurably improved significantly with expansion. That is not to say that people uniformly get such, you know, noticeable sleep related benefits. Some do, and some will maybe, you know, at least have improved breathing as a means of then facilitating other aspects of sleep therapy, right? And so that is that's, I think, an important distinction is breathing and sleep. I think, you know, anybody and their mom who gets expansion will probably breathe measurably better. And there are, of course, objective ways to measure that. And then seeing like a whole UARS symptomology pattern, you know, I think that we of course qualitatively see that it's overwhelmingly successful in reducing the pressure of symptoms on an individual and their quality of life. But, for me to come out here and authoritatively say that I have data to support that statement, I can't necessarily say that, except for just, kind of,
What you hear patients
saying
say.
what we've seen, from our patients. Yeah.
I mean, just being a patient, I can say that having had, as most of you guys know who know me, 2 nose surgeries. One was turbinate reduction and septoplasty, and done multiple allergy tests, and I just really run the gamut with how can I breathe better through my nose, and was given no other options. And then when it came to expansion, that was the single only thing that worked for me. So I know not everybody's story is that, but I'm wholeheartedly like an expansion lover, because
Enthusiast.
yes, there it is, enthusiast, because it really did work for me. And of course, it doesn't solve every problem, like sleep. Sleep breathing is kind of its own demon. But that upper airway resistance, man, it does lessen when you have more volume. It just worked
Absolutely.
for me. So yeah, I'm a testimonial for expansion 100%.
Well, and let me give the viewers just a quick, I guess, mechanical explanation of why that might be the case, right? So, I mean, we all know that expansion improves nasal and upper airway volume, right? But the characteristic of a lot of UARS patients is that we have, we basically, it's an effort issue, right? It's an effort with receiving and materializing the oxygen that we're able to intake, right? And it's a matter of also having too much input or load, neurologically, that then alters and modulates the arousal threshold response and all that kind of stuff, right? So all this stuff relating to effort and arousals, right? Of course, has a structural explanation, also has a neurological explanation. Now, what expansion is very unique at, right, in its therapeutic potential, is that small amounts of change will give you a combination of more anterior window of receiving the air, that's your aperture opening, more posterior volume in basically getting more air through the nose into the back of the throat. It doesn't take much of a linear gain in expansion to produce large, or at least clinically significant, I should say, volumetric changes in the nose and even the oral cavity, right? And so in the oral cavity, those volumetric changes, of course, improve not only the physical amount of space for the tongue, but something that I talk about from time to time is the proprioceptive, basically the proprioceptive sensitivity of the tongue. The tongue responds a lot, especially for some individuals, to that feeling of being trapped, from that feeling of being sort of encroached upon in space by the teeth. And so by doing expansion, you reduce some of that as well, which for some people means that neurologically you have less input, right? You have less input from the tongue proprioceptively because of structures kind of pressing up against it, right? Of course, the observable effect of that might be something like scalloping or just feeling like your tongue doesn't have enough space, right? But even that reduced pressure can amount to some reduction in, neurologic input as it relates to all this stuff that has to do with the real estate of the nose and the oral cavity. And of course, we talked a little bit about TMJ decompression, right? And something that I've seen phenotypically as one of the sort of patterns of individuals. And this is not that everyone has this pattern, but this is one of the phenotypes of UARS individuals. And that is TMJ compression, right? And why is TMJ compression, with or without the presence of classic TMJ symptomology, right? Why does that contribute to upper airway resistance, right? It's TMJ and it's upper airway resistance. So like, what's the connection, right? And the connection is that you have the highest upstream movable joint in the body, with very delicate little structures in there. You got nerves, you got blood vessels, you got delicate, soft tissues in there, retrodiscal tissue, and so forth. And they are being smashed in an individual whose condyle is too high up, too far back, or maybe even sometimes too high up and forward as well. And so you have all these, kind of inputs as a result of that. Then you have downstream other postural compensations and other things like that. So that's, of course, that for the nervous system, that's like a lot to kind of think about at one time.
Yeah.
Right. So that's one thing, plus the actual physical nociceptive input, right? The pain input that comes from that compression sometimes in some individuals, if it's bad enough, right? So that's one sort of phenotype of UARS individuals. And I see that kind of goes hand in hand with another thing that I see very commonly. I've talked about this to a lot of, patients who present with this particular issue, is a lack of the posterior vertical dimension of the face, right? When you have diminished posterior vertical dimension, what I mean by that is kind of the distance, in height back here,
The
maybe
ramus area?
from the ramus area, right?
Okay.
And basically you have your ramus area. And then also it's not just the length of that ramus, but it's also its orientation in space, right? And why might it orient in an unfavorable way is because the posterior maxilla is tipped up, right? If you're looking at somebody right from the side, then you might see that the posterior maxilla might be a little bit high, right? Maybe that individual has a steep occlusal plane. Maybe they don't have a steep occlusal plane, and maybe the whole maxilla is vertically deficient. But particularly, I think that what we're going to find is that there's a very direct link between posterior maxillary vertical deficiency and upper airway resistance syndrome. Everybody mark that down, because that, I think, is just too much of a coincidence in my observation that it's not actually a very strong predictor of UARS.
Perhaps this will be part of your future research.
Yeah, but
what we'll be reading in 5 years.
Yeah.
All right. Keeping it moving. So what are some alternative protraction methods you're currently giving to FME patients? So what would you prescribe to me, Dr. Newaz, if I'm like, all right, we're going forward with that next FME, but I want to protract, but FME is not available. What are we going to do?
You got a thumb pull max, bro.
I have fingernails, so it makes it harder.
You gotta cut them joints off. Oh, what are you even doing with them things?
Just wear those fake thumbs that go over.
Yeah, you gotta get rid of those when you get your FME. I need you manually manipulating your own palate, and I need you disarticulating that posterior maxilla off those pterygoid plates. You can't be having those.
Okay, so alternative, is that the only thing you're gonna prescribe me?
No, we have. Well, there's some ideas here, right? Of course, I just took a rudimentary regular kid's face mask, and I was able to hook rubber bands up from the posterior, right? So depending on how the FME is situated in the palate, this could be appropriate, especially if somebody's wearing a retainer or an aligner, right? And this becomes even more appropriate if somebody maybe has, a need to control the vertical position of the front teeth, because that rubber band is going to come out as it emerges and probably make contact with the incisal edges of the front teeth.
So you're saying, I know this is the Pro, right? But you're saying like wrap the elastics around this whole entire device, right? And then so it's going to come forward because it's going to be on the palate, so it'll be under the front teeth. So you're saying wear like an Invisalign, right? Do the no diastema protocol basically, and then keep the teeth where they are under the pressure of that elastic coming forward. Just to make sense of it all. That's what you're saying, right? Okay.
Effectively, right? And of course, if that collateral force vector on the incisors is not otherwise unfavorable for you orthodontically or whatever, right? For you, it happens to be a favorable thing.
Well, would it be though? Because I have vertical maxillary excess. That's always hard for me to say. Vertical maxillary excess.
So that would have intrusive pressure on the anterior segment for you.
But I thought like the downward vector of the elastics would pull the maxilla down, but you're saying,
Well, that's a loaded that's a loaded thing to consider. Why that is
okay,
because just so everybody thinks pulling down is going to make the maxilla come down, right?
yeah,
Pulling down from the back specifically, while you actually have that same rubber band sling pushing up on the anterior, what's that going to do? It's going to help actually
like
counterclockwise rotate.
intrude. So you're saying
Right.
like if
Of
this
course,
was
I'm
set,
not claiming that that rubber band setup is necessarily
is
ideal
gonna,
for
yeah,
counterclockwise rotation, but I'm just saying that there's a difference between pulling down in the back and pulling down in the front. There's a difference between pulling down in absolute bodily terms, and there's a difference between, maybe trying to get some upward vector in the front and downward vector in the back, right?
I see what you're saying. So like essentially I know this is reverse, so pretending I'm wearing it, but like this thing is what's going to be in front of me. If it's too low, then obviously it's not touching the front teeth, it's just going to pull down. But we're saying if I have this set up so it's high, it's going to go down but then up after it contacts the teeth. It goes down up and then has that intrusive force. I see what you're saying.
And maybe a net level vector if set up appropriately.
Right. Okay. And this is what you are offering, or like as a...
Well, that's among the things that we're offering. We also are offering a hybrid, kind of, dental / TAD supported anchor plate type of thing for people who want to pull from a more conventional, anchor point in the absence of, being able to use the FME itself. So, we have, let's say you put like a multi-unit band around some of the posterior teeth, and then you have a little wing or a plate that goes up, and, you can actually drill into it and, get some bone anchors that way. Right.
Yeah. So how do you connect the FME? Or is that for MARPE?
You're not connecting the FME. You're actually doing protraction independent of the FME, but, still bone support that way.
I see. So it's not connected. You're using the
Correct.
TAD with the face mask. Gotcha.
Correct. And then I have some other patients who have done some really, kind of smart setups with, I've seen everything from like little carabiner belt clip type of little things hooked onto the back bar of it and tie a string and a rope and rubber band and hook that up to a face mask. I've seen somebody with a fishing line hooked up to their desk. I've seen all kinds of things. And again, these patients are smart. They will figure some stuff out and they run it by me to see if the force vectors make sense. And, we'll talk about it. And that's kind of what people are doing. Do I have enough, has this gone far enough for me to know how effective it is or how much of it is actually attributable to the protraction effort rather than the expansion itself? I don't know how to stratify
Yeah,
that.
that was going to be my next
But
question.
it's kind of like, when you're doing this kind of work to augment your midface, you're doing kind of anything and everything. So if we're being practical about it and not academic, I support that, right? If we're being academic about it, you have to control for it. You have to then get 50 people doing it this way and 50 people doing it that way, and control for variables, right? To understand what you can attribute your result to.
You hear that, Facegenics? We're desperate. Hurry up. Where's FMA? This is the community cry. Where is FMA? We need you. Somebody asked, do you think the FME Pro will be the last general iteration of the FME? And do you know when it will be available?
Was the iPhone 4 the last iteration of the iPhone?
Touché.
You know what I'm saying?
Yeah, if you were to ask me, I'd say probably not as well, because they're still in their developing years as a company, and it sounds like they are open to feedback and continuing to change with what's happening in real time with patients. So when's it going to be available, this FME Pro? Do you know?
One went into Dr. Manueli's mouth last weekend.
He's special. He's a doctor.
No, but it's orderable. It's orderable. They have a limited supply that they're reserving for some individuals known to need it. No, not well. And this is this is basically something that's going to be maybe constrained by some initial availability, but it's basically what is coming out, right? So there are some out there and available, right, for individuals who may have a unique need for it at this time.
Well, thanks for being very patient-centered. I think a lot of us really appreciate that. Somebody wants to know, is FME actually superior to Custom MARPE in terms of maxillary and nasal cavity expansion per millimeter of transverse expansion?
Listen, it's our observation that, we think that the yield from FME is very good. Okay. We do see that, generally speaking, I think that statement is true, but maybe not by a wide margin. I think that, again, that remains to be studied. I don't necessarily want to be in the business of taking too much of a strong side on this issue without more proper data and understanding. But yes, it is our general observation that the yield is very good. Just pound for pound, right? Millimeter for millimeter, we see very good nasomaxillary expansion effects. And we think that that's attributable to some geometries and guardrails built within it.
All right, moving on. Is a face mask necessary with MARPE, since the MARPE itself protracts enough? What do you think? I'd hate to torture myself with a face mask unnecessarily. LOL. Whoever wrote that, same.
Yeah, I think, well, this is actually an important point, okay, because there is natural protraction of the maxilla that happens with circummaxillary disarticulation that results from expansion itself. If that is the case, then for a lot of people, that amount of protraction is probably clinically significant and may, bypass a need to do more, right? But again, this all is dependent on the objectives of the patient. It's dependent on, aesthetic considerations. It's dependent on functional considerations. It's dependent on choice making with respect to additional interventions, most namely jaw surgery, right? Should somebody, spend 6 months protracting their maxilla when they're going to get jaw surgery anyways? Well, maybe even for some individuals that does make sense, but for most, maybe it would be low yield effort, right? But yes, is there a situation where it actually could make sense to protract the maxilla and also get double jaw surgery? Sure, because you're bringing upper parts of the midface forward to produce more balanced aesthetic outcomes for somebody who is wildly midface deficient, right? And let's say for airway, you're going to need large amounts of expansion, right? Protraction, right? You're going to need large amounts of advancement, and then you're leaving behind some,
Here's the forecast for
flat
tomorrow.
zygos.
Sorry, Alexa just decided to talk to me.
Yeah, buddy.
Damn, Alexa. All right, keep it going.
Yeah, no, so that's what I'm saying, right? Like, why would you want to leave behind some zygos, right, when you're doing large advancements? Sure, there are surgical solutions for that issue and ones that are pretty good, right? But, sometimes we want some of the upper midfacial gains if they're otherwise aesthetically and functionally appropriate to pursue.
So it's just really hard to say if it's worth it or not, and like separating it from whatever you naturally get with expansion. In adults, it's hard to tell if wearing a protraction headgear is worth it at this stage.
I think you've summarized in your question what I've basically said in a very roundabout way. Sure.
Okay, but
yeah, I mean, well, again, it's very individualized. Is it worth the effort, right? Somebody has to ask themselves that question. Is it worth an extra 1 or 2 millimeters for something that is patently unpredictable in adults, right? But again, what alters the predictability is the observable disarticulation of some of those more resistant suture groups. If you can see disarticulation, then the maxilla is definitely more receptive to protraction, and maybe somebody's likelihood of actually achieving protraction is higher, right? So that can also be considered, right? And I do think that protraction will be, and I've, of course, been on the record for saying this, I do think that protraction will be a frontier that is, currently underappreciated and will be very appreciated in the future as far as its utility for airway and facial, maxing purposes.
Yeah, we hope so. This community
Yeah.
really hopes so. And that's why it's prescribed alongside MARPE, FME, and not just in braces because of that.
Mm-hmm.
Would you call it
Axillary.
maxillary
Yeah.
disarticulation? So essentially the whole maxilla becomes loosened and possibly can be protracted. Fingers crossed, all of us. Okay, next question. Since posture from the whole body can affect head posture and also facial asymmetry, usually stemming from the pelvic hip areas, would fixing these issues be recommended to fix before MARPE?
Great question. I think my answer is, the more I think about this issue and the more I treat patients who are treated interdisciplinary, the more my answer becomes yes. And the more my answer becomes that we really need to start respecting this interplay as a profession. This is very important stuff. And, I think that we definitely need to consider, what I call the head carriage in space, right? The head is being carried and, kind of just held by the C-spine. And so the C-spine itself may have its rotations and deflections and, inclinations
Guilty as
of
charged.
that. Yeah, buddy. And that modulates the head position in space. So if we are, I think planning has to be anchored in the cranium. Obviously, we can't necessarily like plan an FME according to C2, right? And its, rotation. But, you want to anchor the planning in the cranium and the cranial structures that we classically use for planning and, centering an FME in somebody's skull to optimize the vector. But you have to think about how that very head with that FME in a very idealized position is going to respond in space, right? And I've also learned to know that there are ways that, of course, there's the actual moving of bones that can happen, with orthopedic interventions, but there's certainly small amounts of maybe release and mobilization potential that comes from, and some reduced resistance and maybe some unwinding of torsions that can happen with manual manipulations and postural, work to idealize, certain things. And I think that those can actually have observable, measurable effects, right? And I do think that that is good precursor work for somebody who's going to embark on expansion in a very kind of twisted, contorted sort of cranium and C-spine.
Guilty as charged again. I'm not that twisted, I think, in the head, but just slightly.
Yeah, no.
Twisted in the head.
Your ass ain't that twisted, I mean, you just got a little bit of a head carriage orientation issue that definitely affected, the observable left biased kind of nature of your expansion. But actually, when we overlaid it, we actually saw that the right side actually physically expanded a tiny, tiny, tiny bit more, right? And so what do we say to that, right? Like, how's the left looking so prominent when the right actually expanded more, right? And it's because of this issue.
Little torsion
and it's
thing.
something that definitely needs to be considered.
Yeah. So from a patient perspective, I'd say, especially if you have pre-existing asymmetries, I think that interdisciplinary approach that I was talking about earlier that, was heavily discussed at the Winds of Change event is really worth, if you have the resources, I think it's really worth your time to just have a bunch of people working on your body as a whole. All right. Next question. Is there a way to actually encourage the vertical drop and forward growth of the maxilla during expansion with FME?
Great question. Yeah. I mean, I think that, that's actually interesting question. I think that does rely on some outside force application, right? If you maybe, let's say we made an outside plate, right? Or, you did a MARPE or something and, you did even like a MARPE-like attachment, but, you just have to anchor this thing in bone somehow, right? If you can anchor something in bone and then again apply the right kinds of vectors, right? Maybe you need also an anterior plate to pull down on, right? A lot of people have anterior maxillary vertical deficiency, right? What is that? That's kind of like your classic bulldog bite, right? Your whole maxilla is embedded up in the, up in the cranium, right?
Yeah.
Tethered, very high, with the sphenoid bone. And it's so sunken in that, you have no smile display, right? You have a very short nasal maxillary complex altogether. You have a very disproportionately short middle third of the face, right? And so you may want, right, a down and forward migration of the maxilla, right, to improve smile display, right? A lot of orthodontic surgeons will do a small small clockwise rotation of the maxilla when they want to improve smile display on individuals who are like too tipped up in the front, right? So we have to consider, I mean, it's really just about applying the right kind of force to this very dynamic system, right? And of course, understanding how that all interplays with how the sutures come apart. And, one has to almost continuously reevaluate the ongoing effect of the expansion itself on that very complex system, right? So that you can see that, hey, is my FME really resisting the vertical, kind of pull down? Or because of how that individual's bones are all kind of wound up in the cranium, is there a natural, kind of slight, downward, migration of the anterior maxilla, right? Again, everybody's cranial bones are tethered differently, right? And so if you have release of those tethers from the same suture groups that are opening up, but what is the effect of those suture groups opening up for that individual? That's very important to appraise during expansion and to help guide extraoral force vector application on the complex.
So follow-up question to that, do all expanders create some downward drop? Like, is that expected with all expansion?
I think it's fair to, if one has to generalize, I think one should assume, right, that there should be a little bit. Of course, it's a matter of how much control you have with that drop. Now, why does that even occur, right? It occurs because the maxilla has bone connections superior and posterior to it. And the ones that are posterior to it are from bones that are inherently higher up, right, in the skull base, sphenoid bone, right? So,
These little guys
with
we're
that,
talking about?
and of course, superficially, right, then yeah, you have, you basically have a frontal bone connection. You also have the, zygomatic going into the temporal bone connection, right? Those sutures can come apart, right? Zygomatico-frontal,
Like right there?
zygomatico-temporal. Yeah,
Okay.
exactly. And then
Saying
you're
all the way up
brown
to
and
here.
yellow. And then, yes, you have frontomaxillary, nasomaxillary, right, areas. And that area disarticulates, right? These bones can't go up at these interfaces, right?
Yeah.
But can you get infraorbital, right? I saw this question in the sidebar. Can you get infraorbital advancement from FME or from, MARPE for that matter? You can. How do you get it? Well, of course, with the little bit of disarticulation that occurs, the maxilla and, this whole sort of upper midfacial apparatus kind of comes down and off of those bone connections. How it does that and how that force gets loaded affects whether you can get that, of course, just the absolute projection of this midface, accounts for some anteriorization of the under eye area, and some may come from a slight rotational component. And I think that if you study, the expansion patterns of a lot of individuals, then you'll see that maybe the tendency actually in successful parallel midfacial expansion patterns tends to be slightly counterclockwise, right?
Counterclockwise being right this way.
Yeah.
Right. Cool. Hope that helped. And I know that Ron has done, and other people have done that like example where they peel this apart and you can see how it actively moves down. I can also say that having had like 2 expansions and the gummy file, the gummy smile gets worse, but then once we do orthodontics, it seems to fix a little bit of it. It doesn't all go away, but there's some amount, and I don't know if you're going to say you see this, yes, in your practice, that actually gets fixed once orthodontics gets put on. Is that not
what gets fixed in particular?
A little bit of that downward drop seems to actually come back together and come up slightly. At least it has for my case twice.
Mm-hmm. Mm-hmm.
Once you
I think orthodontic mechanics, of course, applied intentionally can help offset that. And it can also help accentuate that if that's what's desired for more smile display and so forth.
So you have control, you're saying. Got it.
You do have some degree of control. Right.
Okay. Next question for patients with UARS. And for those that don't know, that's upper airway resistance syndrome. Doing FME while using CPAP or BiPAP with EERS and drug use to suppress spontaneous arousals, what protocol have you used, if any, to titrate off of the PAP while achieving expansion?
That's an oddly specific question. But can you repeat that one more time, just so I can maybe target certain layers of that question, even though I don't think I'm going to be able to answer it in that very particular context, because it'll take my brain a while to access its Rolodex to find the anecdote that matches that particular
Let's break
situation.
it apart.
But yes, I can definitely. Yeah.
So patients who have breathing issues, particularly upper airway breathing issues, who are doing FME, but also while using CPAP or BiPAP, which means doesn't that mean that there's also OSA if you're using, okay, but I won't assume.
Or adjacent. Yeah.
With EERS. So what actually is EERS is my question. Do you know? We got blank.
EERS?
Yeah, we got blank on all three screens. EERS.
EERS. That's actually a good question.
Something resistance syndrome. Let's break it down. Electrical. I have no idea what the EE stands for.
Well, go ahead and answer or list the rest of the question.
Well, anyway, while using CPAP and drug use to suppress spontaneous arousals, what protocols have you used to titrate off of the PAP while achieving expansion? Like, if at all, assumes if you do.
No, great question. So, as far as PAP titration, that's a great question, because we have had some patients who, definitely have to combine, right, a structural modification option with still continued management. We basically have to see if somebody can maybe reduce pressure, get the same therapeutic benefit. There are, of course, like relatively easy ways to monitor those types of things and, see if you're actually getting, there are maybe relatively simple ways to maybe score some of these metrics, through simple handheld devices or, watch pads or Oura rings or whatever. Right. And so you can at least have, at least some kind of tracking mechanism to suggest that, hey, you'd require less pressure progressively to manage your issue. And then of course, I'm going to get into a slightly different dimension here, but it is my thought that, of course, when you have a machine, pumping in some of the air for you, right, that you have a little bit of a down regulation in your body's own, reflexes to actually, put the effort to take in the oxygen, right? For example, if you have a machine doing it for you, your body's going to kind of suppress actually being able to take in the air. So there is a small adaptation period that when we maybe ask our patients that if they're not having a very strong quality of life negative response to discontinuing or at least trialing a discontinuation of their PAP once they've gotten maybe some expansion, or maybe we have another collateral way of managing mandibular position, right? Either through rubber bands, kind of like a half and half hemi-arch sleep appliance type of thing. We've done that for some individuals, right? To get them off of PAP, right? Where you'll actually make a sleep appliance type of thing. And you can even do that with clear aligners, right? You can put mandibular advancement features into clear aligners, either twin block style or mandibular advancement wing style attachments that at least help you manage mandibular position to some degree. And again, just like everything else we've talked about today, you have to control for the variable, right? So you won't know until you actually discontinue the PAP, right? So people qualitatively can reduce PAP pressures and then also qualitatively see how they feel when they discontinue it. But that has to be given adequate time to be realized, because you need to upregulate your body's own reflex to breathe, right? Because you no longer have the machine pumping it in for you.
I figured out what EERS stands for.
What does it stand for?
Enhanced expiratory rebreathing space, which is an adjunct therapy for treating complex central and CPAP refractory sleep apnea by intentionally adding dead space to a non-vented PAP mask circuit.
Well, this is why my name is not Anil Brahma, because you got actual sleep experts who know those kind of acronyms. But yeah, no, that is very helpful. And again, all of this is reason to better understand the mechanics and architecture of sleep as we continue to render these therapies. Of course, we kind of get, kind of pigeonholed as structure modification people. So, but I think it's important for us. And this is just a call to myself, as well as my colleagues, to better understand sleep architecture in the treatment of our patients. But, of course, we're not in a position to diagnose nor directly treat those issues as, I guess I should say, I can't diagnose, upper airway resistance syndrome, sleep apnea without, a physician making that diagnosis with the data provided. But what we can do is take that diagnosis and, of course, provide a sensible interdisciplinary approach to treat it.
Is UARS a diagnosable disorder?
That's actually also a somewhat contentious issue, but yeah, the short answer is yes. There absolutely is, because, well, the easy diagnostics for that are that you have, an RDI that meets threshold, right? RDI above 5 with an AHI below 5, right, is technically upper airway resistance syndrome. But, does that, you have to then, to have a deeper understanding, right, we have to measure, other aspects of, arousal threshold and fragmentation and other things like that. And I think that there can be some, like a kind of a complex web of qualifiers. Again, what I see in a lot of our patients who are good candidates for expansion, they have an aggregation of a lot of minor problems. Any of those problems in a vacuum, not really pathologic. Combination of a lot of small shit going on, that's upper airway resistance syndrome.
Hell yeah. Jumping off the whole sleep thing, somebody asks, is your clinic still planning on doing sleep testing before and after FME to gather data, and any progress so far from that?
Well, I just want to say one thing that I see in the question bar. There's like a very easily answerable question. They said, at what point during the expansion did you notice your TNJ unjam? How many millimeters roughly of upper expansion allowed the lower to release? For me, that was about 4 or 5 millimeters, I would say. Basically you could see breathing gains very quickly. You then start to see consistency and breathing gains a little bit later. And then you start to see some of these other, like, wow, shit, like I have some overjet now. Like, what is that about? Right. And I think it took me about 4 or 5 millimeters to kind of see, like, oh, wow, yeah, I can actually kind of glide my maxilla or my mandible within my new maxilla. So that's just a quick something. For me, it was 4 or 5 millimeters. But yeah.
Sorry, I just now saw the public chat. What's up, chat? So, is it possible to upright the posterior lower teeth with aligners to undo the previous compensation?
Say that one more time.
Is it possible to upright the posterior lower teeth with aligners to undo the previous compensation?
Yes.
I'm assuming you mean like natural compensation, right?
Yeah. Of course, within reason, but yes.
So like the tools in your toolbox are, of course, aligners, braces, tooth-borne expanders for the lower.
cross
Anything else?
elastics,
Right. Okay.
all kinds of stuff, right?
Okay. So various
And
tools
of
in the
course, you
toolbox.
have your surgically facilitated stuff like SFOT and
Yeah.
grafting, phenotype modification, and then you have your mandibular skeletal widening procedures. Of course, those are next level, but at the dental alveolar level, without surgical intervention, it is those things that you mentioned, right? There are other finer details within that also apply, right? Like there are certain types of arch wires that might help you do that a little better. I'm a big fan of the like Australian arch wire. Australian arch wire is basically, it's almost like a little shape memory style wire that comes on a spool. And when you cut, a cohort of that wire, it's just an extremely broad, arch form. So it's a good thing to then put into an arch, into your arch wire tubes. And then slowly it kind of expresses a little bit of a broadening type of effect. So that can be very helpful, but you can generally only apply that once you've done some other leveling and aligning with your teeth with a lighter wire. But yeah, Australian arch wires are great. Lower fixed expanders are great. Cross elastics are great. Aligners are great. Right.
Okay. Question about SARPE. Does it have a space in the future of expansion care? Will it be acceptable even if you can't get a split through MARPE or FME? So before you answer, I just want us to define what SARPE is because I've been seeing it used interchangeably to also explain or describe surgically assisted with like corticotomy and corticopuncture MARPEs. And so I just want to define first what SARPE means.
Okay. That's a great question because at least in my view, and I think semantically as it relates to the profession, SARPE specifically refers to the cocktail of osteotomies or corticotomies that are performed to do expansion in the traditional way, which is to make Lefort style cuts to release the lower, part of the maxilla from, the upper midface and doing an osteotomy in the mid palate to release the mid palate, right? And basically then you can apply any expander, whether that is a tooth-borne expander or a bone-borne expander to produce skeletal expansion. So that, I think, to me is the definition of SARPE, is basically having to make surgeon level full thickness cuts.
So kind of like this. I know this is a 3-piece, right? But here's a Lefort where we're kind of looking at the maxilla a little bit downward like this.
Mhm.
So fully cutting here, right? You're saying,
Yeah.
or some variation of that, right? Cutting.
Yeah, some variation of that. Like semantically, that is a SARPE, but technically, sure, any level of surgical release procedure, whether it's just something as lightweight as cortical puncture, where you're just poking tiny little holes up and down the midline, or a, piezo corticotomy, which is a partial, release of the palate, or if you do a full release of the palate with pterygomaxillary disjunction, we know who does that. And, we have, of course, other varieties of that type of procedure. Really anything that's surgically assisted is surgically assisted. But when we say SARPE, we are generally, again, categorically referring to the old school type of, like make your Lefort cuts and your midline cut and expand and depend on those to expand. Of course, bone anchorage helps overcome the need for all of those osteotomies, most of the time, at least to happen together, meaning, bone anchorage allows you to either, pick, certain smaller versions of that type of release to produce similar or even better effects geometrically.
And I think in the chat, they were saying, no, I think they actually meant the surgical assisted. So it sounds like SARPE has become obsolete, mostly because now we have
classic sense.
Sure. Yeah, because we have like the jaw surgery. So I was recommended a SARPE from a local ortho here, and the jaw surgeon that I saw like basically quoted me kind of the same recovery as jaw surgery. It was like no eating really solid foods for 8 weeks.
Yeah.
So when I hear SARPE, that's what I think too, in that classical sense. But I think that they mean, so I know a lot of people aren't doing a surgical assist anymore. So perhaps that's what this person is referring to, is the surgical assist.
Yeah, I think that, again, surgical assist can technically mean just about anything, but I think it's that, you know what I mean?
Porta-potty.
Great, yeah, exactly. Well, the full release that is surgical assistance. Now, and SARPE is also not to be confused with, segmental expansion in orthodontic surgery. Of course, SARPE, MARPE, all these things refer to essentially a distraction osteogenesis of the palate, right? You are using a distraction device, a device that gradually, stretches the bone over time to produce the desired effect versus doing it in one shot in the operating room. And that is otherwise, also an acceptable procedure and an acceptable way to expand the palate. Of course, some concessions are made, but also some, controls are had that are not also present with bone anchored expansion, right? Some predictabilities are possible that you cannot also get with bone anchored expansion, right? And then even though you maybe, forego some potential benefit of upper midfacial expansion, you also reduce some risks associated with involving those structures. So surgical or segmental expansion also has great utility. And you can also get differential expansion with, Lefort osteotomy style expansion, right? You can expand a little more on the front or a little more on the back. According to what that individual needs, you can put your segments wherever they're needed to optimize arch coordination. With the lower, you can upright and tilt in and out the side segments or the posterior segments in a segmental Lefort osteotomy. So there are, I think that should also be considered when somebody's assessing their own objectives and risk profile for expansion.
So question, what would be the circumstances for you to recommend SARPE to somebody, if any? And we're talking traditional SARPE with the Lefort cuts.
Say that one more time.
And we're talking traditional SARPE with the Lefort style cut.
What about it?
Is there a situation in which you would recommend that to a patient?
No longer.
Okay, so completely obsolete for you, and you don't see it coming back in the future. Okay, cool. Next question. How does the balloon face effect happen, and what can be done to mitigate it? Well, just don't get filler. No, I'm kidding. The balloon face happens for people? That's a thing with expansion?
Well, I mean, if you overdo it, sure. I think expansion magnitude is really your number one protection against balloon facing. Just do a more modest expansion. Like you can't expand like 3-4 millimeters and have a balloon face.
Point taken.
I mean,
I don't have a
so yeah. We should definitely continue this. There's, of course, the field of expansion is a somewhat endless conversation, honestly. There are parts of this that I'll probably look back on a year from now or even a week from now and be like, what did I just say, right? So it's also so evolving. There's a lot to think about. It's a humbling space. And it's a space that tests our, knowledge and creativity every day. So I just want to come out and say that as well, that, it is very possible that a lot of what I've said today is going to become obsolete in 3 years, 5 years, right? We may live in a very different world at that point with as fast as, expansion related knowledge is evolving. I just have made it my intention to be a part of that conversation and that direction of the field and to better understand, again, the head as, basically, something that sits on, whole body. Right. And I think it'll just be really interesting to see how this stuff plays out.
I agree. Thanks so much for spending time with both me and Patrick tonight and going over everyone's questions and going over, where you're at in your expansion provider journey and winds of change.
Absolutely.
I really appreciate it. And sorry, everyone, if we couldn't get to all of your questions, but you'll just have to come to the next one.
There you go.
Yeah, buddy.
Yeah, buddy. Thank you
And
so
maybe next time, actually, I'm going to interview y'all
Oh,
to ask about, the community side. Nobody actually talks about that, right? Like, why am I not actually interviewing you guys to talk about what the community is talking about, right?
I love that.
Of course, we're a bit more community adjacent than your, kind of average, but like still, right? It's important for us to be there right up in it and see what, it's important for us to understand, hey, what kinds of questions are you guys being asked? What are people interested in? And all of that. Of course, this conversation is a reflection of that, but nonetheless, right, it would be actually very interesting to actually primarily put the focus on that for a bit.
I think it's a
Down.
very good perspective. Yeah.
That's pretty awesome.
So when am I interviewing y'all then?
Whenever you say the word.
Give us a date.
I got
We'll
more
be
time
there.
than you. Sorry, Patrick, we keep talking at the same time. You go.
No, I was just saying, let's mark it. We'll make it happen. I think it'll be a
For
different
sure.
type of call. Yeah, that's what we've done before. It'll be different.
And maybe next time, we should get we should definitely get Dr. Jafari's perspective. Of course, he's he has of course a wealth of knowledge and experience now with the actual practical surgical aspect. Obviously, I do some FME installs, but he's now at this point done way more than I have. We're talking about physical installation. So if you guys have technical questions about the procedure, he's a very good person to talk to. He's also a really good person to talk to about the overall role of full mouth rehabilitation and of course aspects of restorative dentistry that don't get talked about enough in the world of engineering people's bites and occlusions to be in therapeutic neuromuscular friendly positions that have good aesthetics, good function, right? That's an important conversation, one that's not maybe had enough in this space. So that would be great. Of course, Girl Jaw, you spent a lot of time with Dr. Jafari this past weekend in the in the cadaver sessions. So I think that'll be really interesting to hear about some of what you guys have learned. And then, I think that, we should definitely bring, more interdisciplinary people on talks like this, because, again, like I would certainly recommend, bringing on, Dr. Brad Gilden, the physical therapist that we talked about, who's been really a mentor type figure to me in understanding this stuff. And he's very, I guess,
Okay.
versatile in his approaches. Like he's not just PRI. He knows PRI extremely well and also knows a bunch of other stuff, right? And, can have a very multidimensional conversation with the community about the importance of preparing the body to be in a more neutral position to receive structural interventions like expansion, which involve large amounts of force application to a complex structure suspended in space. Right. So this is very important stuff. And I think he'd be delighted to share his perspective on this channel.
Well, as a fellow patient of this community, I would be very interested in that.
Let's go.
Absolutely. I'm thinking that. Let's make it happen.
Well, again, thank you so much.
Doing your thumb pulling and your zygo pushing, everybody.
Awesome. All right. I think we'll wrap up the call here. Until next time.